Hello world, my name is Dr. Shaham Das and I'm a consultant forensic psychiatrist. I live and work in London and I assess and rehabilitate mentally disordered offenders, or what the tabloids might call the criminally insane. I regularly assess defendants in courts, in prisons and in special psychiatric units that are reserved for the most dangerous and violent patients. Although I specialise in criminal psychiatry, I also have expertise in most areas of mental health. So this video podcast series explores a range of mental health topics. It's designed for the layperson who might be interested in learning more about severe mental illness. So I'm talking about chronic, lifelong illnesses that can hugely impact on the sufferer's functioning, like schizophrenia, bipolar affective disorder. I will analyse how these mental illnesses in some cases relate to offending, and I'll share with you a bit about life from the perspective of a psychiatrist such as myself. So this particular episode that you're watching or listening to is about drug-induced psychosis. And this is something I see reasonably commonly as an expert witness for the criminal courts. So as the name suggests, it's a state of psychosis. The most common symptoms of psychosis are delusions, which I talked about in episode 3, if you want to check that out, and also hallucinations. Now, approximately 3 out of 100 people will experience some form of psychosis in their lifetimes. And examples of experiences that I've heard of from previous patients who've suffered from drug-induced psychosis includes like seeing the faces of demons in paving stones in the streets. And another patient described hearing the voice of like an abusive ex-partner constantly swearing at her. But the thing is, they have a very real quality around them, and this poor young woman was absolutely petrified. In this particular episode, I've handpicked a couple of the more interesting and extreme cases of drug-induced psychosis that I've seen in my career. One of the cases led to serious violence. So a man stabbed himself in the cheek and then stabbed his cousin with a pair of scissors. So it's a bit graphic, as you can tell, so please consider this your trigger warning. The other case was a bit more tragic, and I'll tell you the difference between ordinary intoxication, that's just caused by using drugs, and psychosis, and also how the differentiating line can be kind of blurred, which makes it diagnostically tricky for psychiatrists such as myself. I'll also tell you a little bit about how drug-induced psychosis is treated, and I'm going to end with an amusing drug-related anecdote. I'm sure we've all got one. So, why is drug-induced psychosis so common in my forensic psychiatric expert witness work? That's easy. Because unsurprisingly, criminality, drug use, and mental illness all have a very huge kind of overlap or juxtaposition. Love that word. And also because they have common risk factors such as poverty, social isolation, suffering abuse, lower socioeconomic status, and they're even kind of risk factors for each other. So what I mean is heavy drug use can lead to offending for somebody to support their drug habit, for example, or it can lead to mental illness. Alternatively, mental illness can lead to drug use. So for example, some patients take drugs like cannabis or alcohol to reduce their symptoms or to reduce their overall levels of anxiety. So when mental illness, drug use intermingle, the nexus, also a great word, can be drug-induced psychosis. And this sometimes leads to violence, hence these are the cases that I see in court. Drug-induced psychosis is usually caused by very heavy drug use. It's typically temporary, so generally it lasts 2 or 3 days, or basically as long as the chemicals stay in your system. So the most common culprits, the ones that I see, are amphetamine, cannabis, and spice. If you've not heard of spice, it's a synthetic cannabinoid known in psych jargon as a novel psychoactive substance. And spice is causing carnage in prisons all over the country, with hundreds of cases of severe agitation or spice psychosis every week. But that's a whole other podcast. Sometimes people can just have a bad trip, and some cases are heavy drug users. But occasionally, I see people who are drug naive, so it means they're inexperienced in taking drugs. I've even seen a first-time drug user become psychotic, which is pretty poor luck. And I've even seen a case of somebody who was spiked, apparently, with drugs and then experienced drug-induced psychosis, so even worse bad luck. When I'm asked to do an assessment, As you will see in the case that I'm about to recall, it's usually in the context of somebody who's on trial, so that they have to go to criminal court, and they used drugs and they became psychotic and they lashed out, often with violence, which kind of makes sense, especially if their psychosis involves intense paranoia, which is quite common. Occasionally their presentation can be a bit more bizarre. So I remember I once assessed a woman who suddenly developed this delusion. She was convinced that her sister was being forced into sex slavery in this like random house. So she broke into the house and she was charged with attempted robbery. Generally speaking, as I'll expand later on in this episode, drug-induced psychosis cannot lead to a psychiatric defense. So the defendant cannot be absolved of their crime, although there are exceptions, which I'll tell you about. However, to the untrained or inexperienced eye, like the court or the judges, they see evidence of hallucinations. For example, the defendant was responding to voices at the time, or delusions. So if the defendant was making like bizarre statements, or they see evidence of very uncharacteristic, sometimes inexplicable behavior. And very reasonably, they suspect that there might be an actual underlying mental illness such as schizophrenia, as opposed to like a temporary drug-induced psychosis. So the court instructs a forensic psychiatrist like myself to act as an expert witness to make sense of all the symptomatology. And I'm also often asked to assess if the defendant was psychotic, and if they were, if that means they were not in control of their actions and therefore not culpable for their actions. I'm going to start by telling you about a real life case I saw, and the defendant's name is Mr. K. So I want to tell you about a case that I saw many years ago. I've changed some identifying details to maintain patient anonymity, but the essence of what I'm about to tell you is all completely real. So this man stabbed himself in the cheek with a pair of scissors, as well as his cousin, whilst he was suffering from drug-induced psychosis. To give you a bit of background, Mr. K was a gay man in his mid-20s who had HIV. He was originally from South Africa. Previous reports diagnosed bipolar disorder, attention deficit hyperactivity disorder, which is ADHD, and also borderline personality disorder, which I've done my previous podcast about, episode 5. Go check it out. When I assessed Mr. K in court, there was actually little in terms of objective background information available for my assessment. I did find out, however, that he was quite a troubled child, I think is fair to say. There was a lot of challenging behaviour as a kid. He was setting fires, he was like running into roads. He was just, I think, a bit of a nightmare for his parents. And he also grew up in a very difficult environment that was tarnished with like violence and guns and poverty. And he was one of 4 siblings, and 2 of his siblings had died from overdoses, which I think says a lot. And Mr. K came over to the UK in his mid-teens with his mother, trying to escape an abusive stepfather. So clearly a pretty rough background, I think, which sadly is typical for my patient. Mr. K started taking illicit drugs on a regular basis from his teens, including on a daily basis, he told me once, for an entire year. This included crystal meth, GBH, GBL, and mephedrone. And I assessed him about 6 years ago when, if I remember correctly, mephedrone was actually still popular. And Mr. K had engaged with community drug rehabilitation services on and off, though he would sort of potter along and then have relapses into his drug addiction. Mr. K had minimal offending history, so he had 1 formal caution, and that was for driving under the influence way back in 2012. And when I saw him, he was on bail, and he was facing a charge of assault occasioning actual bodily harm, or ABH. So I'll give you a quick scale of assault. So there's like battery, common assault, ABH, then GBH, and then there's with or without intent. With intent obviously makes it more serious, and then whether it's racially motivated also makes it more serious. So this index offence, so his main offence, occurred just after Christmas of 2014. And Mr. K was very lonely, and he started walking the streets, and he met a random man on the street and went back to this person's house so they could have sex. And they did a booty bump. And I have to admit, little naive me back then had never heard of this before, and it sounded kind of enticing. But then Mr. K explained to me that a booty bump involves mixing drugs, usually meth or cocaine, with water and squirting it into your anus through a syringe. So I thought, no thanks, not for me. I think I'll just stick to my hazelnut skinny cappuccino through my mouth hole. Thanks. So Mr. K explained that after taking this booty bump, he became increasingly psychotic. He became extremely paranoid, and he started believing that the police were about to raid the flat that he was in. And he also started to hallucinate. So he was like seeing dragons and hearing roars. And then this man asked Mr. K to leave, presumably due to his increasingly erratic behaviour. And then Mr. K went to the house of another man who, according to the case papers, was suspected of being a drug dealer. And then Mr. K's psychosis worsened, so things just got worse from there. So his cousin, the victim, Miss C, received a text message from Mr. K asking for help and for her to attend the address that he was in. And he kept saying in his text messages that he was burning from the inside. So when Miss C arrived, she could hear Mr. K screaming inside a locked bathroom. So she managed to open the door and found that Mr. K was naked in an empty bathtub in a very disturbed state. He repeatedly kept saying that he was on fire. And what's interesting is that Mr. K had actually completely forgotten that he'd sent this text message in the first place. So he was really suspicious of why Miss C just suddenly seemed to magically appear out of nowhere. So he accused her of being part of a conspiracy against him. So she was like enveloped into his delusions. And Mr. K was holding a pair of scissors and he stabbed them into his own cheek. And then Miss C took her eyes off Mr. K for a moment when she was going to collect his clothes, and she felt like a sharp pain in the back of her head. And Miss C suffered a cut to her head, so she had to go to hospital, and later it was glued up at hospital. And then, but before that, she called the police. And then Mr. K needed 12 stitches, if I remember correctly. So he didn't need like plastic surgery or an operation, but so it wasn't that severe an injury. And after he sobered up, Mr. K reported that he had limited memory of the whole incident, and he was only aware of stabbing himself. And he claimed that if he did strike Miss C, then it must have been by accident, just with his arms flailing around. So let's now talk about the legal issues I was asked to address on behalf of the court. First, fitness to plead. Now, I've mentioned this, I think, a few times in previous podcasts. And as the name suggests, this is like the ability to go through his trial. So how do we test fitness to plead? We use the Pritchard criteria. And there are 6 factors that are considered, including the defendant's ability to understand the charges against them, decide whether to plead guilty or not guilty, and whether they can actually give evidence themselves in their own defence, but most crucially, if they're able to follow court proceedings. And if the defendant cannot do any one of those things, and there are a couple more, they're not fit to plead. So they cannot go through the court process, there is no trial. And there are a few potential outcomes. They could be sent to a psych hospital, and they might even get better and then have to come back to trial in a few months later. Or if it's not very serious, the case can be dropped. But you cannot be found guilty if you're not fit to plead, and you cannot go to prison. At least at that point, as I said before, it's possible for a retrial later on, and then later to go to prison. Anyway, back to Mr. K. He appeared to be reluctant to discuss his case with me when I was assessing him. And he initially was very sort of dismissive about the questions I was asking him, and he often stated that he just didn't know the answer. However, I didn't give up. With repeated questioning from me and some prompting and some needling, it was apparent that actually Mr. K did have the ability to fulfill all of the aforementioned Pritchard criteria. For example, he didn't want to explain to me his comprehension of how the court system works, but when I broke it down into individual areas like what does a jury do, what's the role of a judge, what's the role of a barrister, he couldn't really deny that he broadly understood what it was all about. And Mr. K kept emphasising to me that he couldn't remember his index offence. So that's an interesting question. Does it actually matter if the defendant cannot remember the offence or not? In short, the answer is no. And that should hopefully make sense to you, because criminals could easily just try and dodge their cases by saying they can't remember, because it's actually very hard to prove if somebody's telling the truth. So was Mr. K really telling the truth about having no memory of the index offence? Probably. He probably was. I mean, he was obviously psychotic at the time. If you remember, he couldn't actually remember sending the text message to his cousin, Miss C. And also, to be fair, psychosis, even without drug use, is sometimes associated with acute memory loss. And also acute drug intoxication, getting wasted, even without any psychosis, also is associated with memory loss, as is extreme alcohol intoxication. I'm sure you've probably heard of alcoholic blackouts. Like that time when you did that thing with that person and you know that you shouldn't have, especially because you both work together and now it's kind of awkward in the office and you can't even remember it. Yeah, that thing. So in my opinion, Mr. K was fit to plead. And in the evidence I gave to court, I opined that Mr. D was clearly psychotic at the time of the offence, fair enough, and there appeared to be a combination of factors that led to this psychosis. So according to him, he had slept very poorly for several days before the index offence. He was taking a whole host of medications for his HIV, and side effects can include psychosis. And in addition, it appears that there were a number of social stressors for Mr. D at the time. He'd been kicked out of his mother's house just a few days earlier, which of note was just after Christmas. And it's known that stressful life events can trigger psychosis. But the most salient and relevant factor in this case was his drug use. As I said, he'd taken a new drug named Booty Bump for the first time. In addition, I also noted that his psychosis was intense and it only lasted a few days and then sort of gradually resolved. And this again is very much in keeping with a drug-induced psychosis, as opposed to, for example, a relapse of his previous bipolar affective disorder, which had been diagnosed with years ago. So a relapse of that would much likely have come on more gradually and built up slowly, and it would have lasted much longer. So what I told the court was that, in my opinion, the evidence suggests that Mr. K's psychotic symptoms had a profound influence on his conduct and on his behaviour. It appears that he was genuinely in fear of his life. I mean, he was locking himself in the toilet. He was believing that people were intending to kill him. He was calling for help. He repeatedly said that he thought he was on fire. When his cousin appeared, he thought it was just magic and part of a conspiracy. Stabbing himself in the cheek is a pretty good sign of psychosis, I would say. So lots of indication that he was suffering an acute psychotic episode. So I was asked to comment on the potential defence of not guilty by reason of insanity. How do we assess this defence? It's governed by the McNaughton rules. These are the legal criteria, which I told you about in episode 1, so hope you are paying attention. So the exact detail and nature of the alleged assault appears to be quite unclear. Had Mr. D intentionally lashed out at his cousin, Miss C, as is suggested in the case papers, or had he kind of lashed out accidentally during some kind of physical struggle, which is what he claimed? It's important to note that it's actually ultimately a matter for the court to decide which version of events it accepts. I'm not allowed to comment on factual matters, or I'm not allowed to guess what happened. And if I did, then I could be chastised by the judge for overstepping the mark, or professionally embarrassed by the opposition barrister in court, whose job it is, bear in mind, to undermine my evidence and trash my credibility. So I worded my report very carefully. In my report, I said that my understanding is that if the court accepts Mr. K's version of events, that he took a little break from reality and accidentally slashed Miss C whilst he was psychotic, then not guilty by reason of insanity is not relevant. However, if the court accepts the victim's version of events, which would mean that he intentionally harmed Miss C, then I would have to consider the McNaughton rules, which, as I'm sure you'll remember, were the following. The defendant was suffering from a defect of reason which was caused by a disease of the mind, to the degree that the defendant may not have known the nature and the quality of the act, or he didn't actually know that the act was wrong. Now, I think you could possibly argue that Mr. K met all of the above criteria, right? But crucially, the court cannot accept this defence as a psychosis was a direct consequence of voluntary drug intoxication. So I also gave an opinion in terms of disposal options, and I suggested to the court, and the court agreed, that the offence was not serious enough for a custodial sentence, i.e. prison. So I suggested, and I'm stressing suggested because all I can do is give advice. The courts are allowed to do whatever they want. They're not obliged to listen to lowly old me. So I suggested a community order with a requirement for psychiatric treatment and also drug rehabilitation. So that's basically like a contract. So Mr. K has to attend appointments with his local community mental health team. He has to take his medications. He has to stay abstinent from illicit drugs. And that can be reinforced by doing like regular urine drug screen tests. And he had to attend appointments to drug rehabilitation services. and meetings. And if he breaks the contract, then it's go straight to jail, do not pass go, do not pick up £200. And in the end, luckily, the court agreed. But to be honest, it could have gone either way because the severity of his offence, I think, was just on the cusp. So I think we had a sympathetic judge. And also I think Mr. K's lack of previous offending probably also helped. So now I'd like to deep dive into mental illness versus substance misuse. As I said before, psychosis is like an altered state of mind. It's like being outside of reality. And the most common symptoms are delusions or hallucinations. There are also like more subtler signs of psychosis, such as what we call disorganized thinking. That would include formal thought disorder, which is like jumping between topics so that others can't really follow what you're saying. Bipolar disorder and schizophrenia are two of the most common mental illnesses in which psychotic episodes might occur. And they tend to be chronic, sometimes lifelong, and there's periods of like relapse and remission. But as I said before, a drug-induced psychosis is temporary, usually a couple of days. And the common culprits are cannabis and amphetamines. I mentioned that before. You see hallucinogenics, so drugs like LSD and magic mushrooms also cause drug-induced psychosis, but I see it less often because they're just used less often by people. There's a fine line between what's a normal experience of intoxication, just so a bad trip, and drug-induced psychosis, especially when you consider that the effects of some substances are kind of quasi-psychotic, so like visual hallucinations you get from magic mushrooms. And then to muddy the picture even more, when people withdraw from a substance, so like a very heavy drug user or a drinker who've been using for a long time suddenly stop, then they get withdrawal. And as well as a whole range of physical symptoms and mental agitation, from blood pressure to sweating, patients can also experience temporary psychosis. And then yet another complication, see how hard my life is? Certain substances can cause or at least trigger the onset of chronic psychosis like schizophrenia. So this usually happens in susceptible individuals. And skunk is a very common risk factor, or a very common substance that causes this. And this tends to be in people who have genetic risks for schizophrenia, so if they've got family members with this particular mental illness or similar mental illnesses. So just to be clear, I'm not saying that skunk is generally dangerous for most people, because it's not. For the vast majority of people that take it, it makes you feel floaty and happy and harmonious and hungry and enjoy mediocre music. So I've heard, anyway. I'm just saying that for a small group of individuals, particularly with severe mental illness in the family, it can be dangerous. So to say that cannabis is always a safe drug, I think, is also misleading. Now, I'd like to tell you about a tragic case of mine, which for some reason just really kind of stuck with me. And this is where drug-induced psychosis led to a prolonged relapse of mental illness. So I remember one young man who had very severe schizophrenia, and he had an exceptionally fragile mental state. And his name is Mr. Z, or Mr. Z for our Yankee cousins. And he was young, he was in his mid-20s, but he had this baby face, and he always kind of reminded me of a teenager. And his index offence was that he stole a car whilst he was psychotic, and he intentionally crashed it into this barn. And that was all related to grandiose delusions that the barn was covering sacred land, and he was convinced that on the other side of the barn door there was like a portal to the other side of the universe. And he was on a forensic psychiatric ward for years. And I remember seeing him get better very slowly with antipsychotics. He took longer than most patients, almost an entire year before his psychotic symptoms eventually assuaged. And we had to trial like 3 or 4 medications before we found one that worked. And he didn't want to take the medications, and it just got very messy. And after months of stability on the ward, Mr. Z went AWOL on leave, and he just went on a massive drugs binge. And he was brought back by police, and he was just really distressed. He lost his shoes, he was covered in bruises all over his body, and it was really upsetting even to see him. He was scratching his own face, he was pulling out his own hair, he was just really agitated. And he needed to be nursed in a seclusion room for over a week. So a seclusion room is it's like a locked room for psychiatric patients on forensic psychiatric wards when they're so disturbed that they're too dangerous to have out on the main ward. It's what used to be called a padded cell. And one of the key areas of work for a forensic psychiatrist who's based in a hospital is deciding when patients are too violent to be on the ward and when they need to go to seclusion. And then also the role involves assessing them regularly and deciding when they can be released onto the ward. And if we get the decision wrong, and if we keep them in seclusion for too long, then obviously it's a massive infringement on their freedom and their well-being. But then if we get it wrong and we release them too early, then there's a risk of assault on staff and patients on the wards. I've got loads of fascinating stories about patients in seclusion, and there's definitely a future podcast episode about this. But anyway, now back to Mr. Z. So even after Mr. Z left seclusion and he was back on the main ward, he was just really unwell. He was just a bit vacant. He had poverty of thought and poverty of speech for several months, so he just barely said anything. And just by looking at him, you could tell that he was just really struggling even to form basic thoughts. And I felt really sorry for him, I did. It kind of reminded me of some patients that I treated many years ago when I was a junior doctor and I used to work in an old age psychiatry ward, and they were just constantly perplexed, confused and disorientated. It took Mr. Z about 8 months to return back to where he was before his binge in terms of his mental state. And I don't care how good those drugs were, it couldn't have been worth losing months of his life and his sanity. So I'd like to talk a little bit about the treatment for drug-induced psychosis. The main treatment is patience, and I mean patience, not patience. Medications such as antipsychotics and sedatives can be used. The actual reversal for psychotic illnesses like schizophrenia can take 4 to 6 weeks for medications to reach their full effect, but the sedative effects can start within half an hour. So the drugs, as in the illicit drugs that the person's taken to get drug-induced psychosis, actually flush out of the system way before the antipsychotics actually kick in. But the medication can still help to calm the patient down and can clear the fog of confusion to a degree. Obviously, after you treat the drug-induced psychosis, if there's an underlying condition, this can then be treated. So drug addiction, for example, but that needs a degree of insight and motivation from the patient. There's different opinions on whether to admit patients to a psychiatric ward if they've got drug-induced psychosis, and it's a bit of a contentious issue. They're not likely to end up on forensic psychiatric wards where I work, because those wards are for very dangerous patients who have complex mental illnesses and long-term needs, which isn't the case for drug-induced psychosis. So somebody with drug-induced psychosis might go to A&E and they might stay there till they sober up, or they might go to an acute ward within a hospital, so not a psychiatric hospital, I mean like a normal routine physical hospital. Although some would argue that it wastes a bed for somebody who really needs it, but that's not something I'm going to get into. There's a massive shortage of psychiatric beds in the NHS right now, as you probably know. Occasionally, somebody with drug-induced psychosis might go to a short-stay psychiatric ward if the level of agitation and aggression is so uncontainable that they just can't be treated anywhere else. They need constant supervision. Of course, the psychiatrist who admits the patient to hospital doesn't always know that it's drug-induced psychosis, because the patient might not tell the doctors that they've taken something. Especially if they're already paranoid and psychotic when they're being assessed. They might not even be in a fit state to kind of relay any kind of information or history properly. So moving on, I'm going to tell you guys about a funny case. This is related to a patient that was high on drugs. So a good friend of mine worked as an A&E doctor in London, and one busy Saturday night, I think probably about like 10 years ago, this young man had come in and he was feeling all tingly. He'd taken ecstasy at a house party and told his friends that he was feeling tingly, and they suggested that he came into hospital to be assessed. So my friend, the doctor, took his blood pressure and his temperature, and basically, apart from like a high pulse, the guy was fine. So my friend kept him in for an hour just for observations, just to make sure his symptoms hadn't sort of spread, which might indicate an underlying neurological issue. And well, whilst my friend was busy seeing other patients, because it was a Saturday night, and as you'd expect, it was busy with like car crashes and fights, my friend would come in and check on this guy every 15 minutes or so. And basically this guy was like dancing alone in his cubicle to the really quiet music on the radio on the nurse's station. And my mate asked him after about an hour how he was doing. And this guy said that the tingling had gone and he was feeling amazing. And he actually gave my mate a hug. And then my friend discharged him. And on his way out, this guy went around the staff in A&E complimenting them, just give it on their hairstyles and on the clothes that they were wearing, even though all the clothes were the same A&E blue scrubs. And at one point, he was telling everybody about how amazing the lighting was in A&E. And then he left, presumably to go back to the party. Now, obviously, I cannot recommend that you get high, but I can recommend that if you do get high, maybe just stay with your friends. Or better yet, get friends who don't ruin your high by sending you to A&E for no reason. But the take-home message, kids, is this. Don't go to accident and emergency unless you've got an accident or an emergency. That's all for this week's podcast. Next week's podcast is going to be a bit different. I don't usually talk about murder cases that I'm not personally involved in because there's literally hundreds of podcasts about that, some of them very good. But there's a landmark case that me and my peers were specifically taught about during our training in forensic psychiatry because it changed the whole face of how forensic mental health works. In particular, criminal profiling, and it exposed criminal profiling to be a sham. And this was the brutal, completely random and unprovoked, senseless murder of a young woman called Rachel Nicholl. She was an ex-model who was murdered in a park in London in 1992 in front of her 2-year-old son. Yeah. And I'm also open to suggestions. So if you're listening or watching this, and if you've got any particular ideas, anything you'd like me to dissect from the perspective of a psychiatrist to inform yourself or other people about, then please hit me up. I'm all ears. So, subscribe to our YouTube channel, follow us on Instagram, like our Facebook page, and submit an episode idea or any questions to our email, which is psychforsoreminds@gmail.com. And if you want to reference us, use the hashtag #PsychSore. That's it. Until next time, stay euthymic, homies. Hello. I've just got a quick add-on to this episode because I've got some news, which is that CrimeCon, which is a massive convention in the States for true crime enthusiasts, is holding its first ever event in the UK. It's going to be in London on the 12th and 13th of June, and I'm honoured to say that I'm going to be part of it. So I will be presenting a talk and talking about a couple of gruesome cases that I've assessed personally, and on top of that I'm going to be involved in recording a podcast episode live there. So that's going to be at the Leonard Royal Hotel and Spa on the 12th and 13th of June. You need to cop those tickets because I think it's going to sell out. And on a separate note, I'd also like to shout out a podcast called Riddle Me That True Crime. I've just gotten into it very recently. I love it. Really well written, really well structured. It dissects real life crimes. It talks you through the actual event itself and the police investigation. And what I love the most about it is it really questions what the police did in a very open and honest manner. So I've just listened to part 1 of an episode called The Mystery of Death Island about 2 English tourists who were murdered in an island in Thailand. And the second part of the episode has come out today. Not yet had a chance to check it out, but it's on my to-do list. And I'm hoping to collab with that podcast and with the host Jules within the next few weeks. So look out for that. Right, that's it. That's all I have to say. Till next time, stay euthymic, homies.